Okay, good evening, everybody, and we are live now. We can go ahead. Over to you, Jan.
Okay, good evening, everybody. This is Dr. John Mukhopadhyay, and welcome to this program, which is for DNB students as well as postgraduate students. And today's webinar is going to be on orthopedic instruments and implants. And we have the good fortune of having Professor Ananda Kishor Pal from Kolkata, who's going to be giving the talk and showing various instruments and implants, which is an important part of the oral examination, both for the DNB and the postgraduate students. So
we are now going to describe the part 2 instrument, that basically the screw nail plate. So what is screw? Basically, it is a machine which convert the rotational force into the linear force. Basically, the compression and the tension, as you can see here. So what are the types? The types depending on the different size and different materials is used. Suppose this is the corticals and this is basically the canceller screw. As you can see here, it may be tapping, it may be non-tapping, it is a self-tapping, self-tapping, self-drilling screw like this. There are several designs, there are utilities used, as you can see here, cortical cancellers, Herbert screw, there's headless screw, the malleolar screw, the polyaxial like that. Now, there are several differences. So, and this is very difficult to cover up all the causes, all the parts, all the basic points. Just I am mentioning the different points, which is basically important to know for your clinical practice, for your knowledge, as also for the examination purpose. As you can, there are differences. There are several differences, as you can see here. I have already told there are parts. What are the parts of these screw? As you can see here, this is the head. Just by the side of the head, the part which is on the side of the head, it is basically the countersink. You see the shape of the countersink, it may be spherical or it may be conical. We'll come with what are the utilities of this conical and crucial and the rounded or spherical countersink. Now the junction, so if there is any smooth portion between the head and the screws, that is basically the shaft, and the junction of the shaft and the thread is basically the run out. This is known as the run out, and this is the thread portion. Now inside that, the exact diameter of this stem, it is the core diameter, and the thread is the outer diameter of the thread is the thread diameter. Now, what is the weakest point of the screw? This is usually asked. Weakest point is the screw is this run out portion. This is the junction of the shaft and the thread, and also the core diameter. So see, depending on the core diameter and the thread diameter, we can divide it into cortical and the canceller screw. If the core diameter is much more in respect to the thread diameter, so this is basically it's a cortical screw, where the core diameter is small, very small. But the thread diameter is much more. So in that case, it is a canceller screw. So this is basically this is a canceller screw, and the cortical. See the tip. Maybe there is this rounded tip. It requires some tapping. Tapping is a special instrument which usually cuts the thread, whereas there are some it is maybe fluted. You can see here it is a fluted. It may be self tapping. If that flute extends up to the tip with the rectangle with a positive rake angle, so that means it is a self tapping and self drilling also. Now you see the threads. So the thread design, it may be a V-shaped. You can see this is the V-shaped thread, or it may be a buttress thread. See the buttress thread. So buttress thread, basically it may be it is a flat surface, that is an inclined surface. It is meeting at almost 45 degree, whereas a V thread, both the inclined surface, they actually meets at angle of 60 degree. So basically what happens, so during once the insertional screw is inserted, this strength, that is the compression, the strength, actually they are basically divided into shear force and also the tensile force initially, and the tensile force is converted into the compression force ultimately when all the threads are engaged. So basically this shear force is detrimental for the screw purchase, whereas this tensile force is most important. So basically I'll come. So how the tensile force is converted into compression force. Now, buttress thread only exert the compression force, whereas the V thread transfers the compression as well as the shear force, which cause the bone resorption, reducing the pull-out strength. So, in that sense, the buttress thread is much more important. And in some screw, the buttress threads are placed in a reverse direction. Normally, what happens? This flat surface, towards the head, and the inclined surface will be towards the thread for easy insertion and for increased purchase power. No, that is that it indicates it provides only the compression force. But if it is placed in a reverse direction, that causes that basically it is placed for removal, easy removal, because during this removal, because of the reverse, once it is moved in reverse direction, that actually cuts the bone, that will help in removal of the example is the cannulated hip screw. Now, the lag screw principle. Now, let's see the lag screw principle. So, lag screw should be introduced at right angle to this surface. And basically, there are two holes are prepared. One hole is relatively larger than the thread, so that there will be no contact on the neocortex. Mainly contact is the thread. It will be purchased on the far cortex. Normally, what happens with if the adequate hole is created, and depending on the coat diameter. So what happens? There is normally the 80% purchase occurs in the neocortex, only the 20% purchase occurs in the thread hole. So that is a normal purchase. But if we make a gliding hole, that is the diameter is much more, so that no purchase will be on the neocortex. Maximum purchase will be occurred on the thread that on the far cortex. That dragging the far fragment towards the near fragment. That is basically the principle of the lag screw. So in that case, so there is an over drilling is required. Now I will show which proper drill is required for the proper screw in the next slides. Now there are some screws which has a specific this type of tip, which is known as a trocar tip, especially the malleolus screw. Malleolus screw, it is a head, it is a countersink, it is shaft, run out, and the thread which is a very thread diameter is not very much. It is looking like the cortical, whereas the see the tip is like this. It is known as the trocar tip. This trocar tip basically it doesn't require the tap. It actually cuts. It actually cuts the its pathway. Basically, this trocar tip screws is usually seen in malleolar screw. Malleolar screw it is seen in this like this. It is a half threaded screw like this. The thread length, maybe there are two types, 16 millimeter and the 32 millimeter. There are other screws like the sun screw, which has a trocar tip, as also the locking bolt for interlocking nail, which has a trocar tip. Now there are some headless screw like this. So how it helps? See, this headless screw, this is known as the Herbert screw. It has a larger thread and this is smaller thread. Larger thread it's at one end and smaller thread is another one, and it is inserted in this manner. So what is this? This larger thread helps. Basically, actually the distance covered by the one thread once it is turned. This is the actually known as the lead. So as the threads are much larger, so in this area the much more distance is covered by single turn, whereas one single turn, that very small amount of distance is covered in this area as the threads are small. So what happens? So in this area, if suppose the fracture is there, the bones are much more it is going nearer to the distal cortex. So in that sense, that causes the compression of this near fragment to this far fragment. So even without the presence of the head, because of this larger and smaller diameter thread, that causes the compression. At the same time, there is some other external compression device that can be added with that. So that is the basic difference. So this is the Herbert screw. Another is the Accutrack screw. This Accutrack screw is also a headless screw. There are several other fractures like the radial head fractures, phalanges fractures, carpal fractures, metacarpal head fractures, and proximal force scaphoid fractures. In this case, Accutrack screws are used. So why tapping is required? I already told, when the screw is inserted, that it may be vertically or it may be obliquely to the surface. See, if it is a vertical insertion of the screw, that causes the rotational torque. And this rotational torque is divided into shearing force and the tensile force. So once it is inserted, the initial tensile force is ultimately converted into compression force when all the threads are exhausted and the head abuts against the surface. Then the compression force is exerted. So if it's a non-self tapping screw, the shearing force is very less, and the maximum force is used to or to for the to production of this compression force. So this is the maximum force is is already used it, and so that causes the maximum purchase power. Whereas in the self-tapping screw, maximum force is used to overcome the shearing forces. Shearing forces. So very less amount of force is required for the compression force. So purchase power is very less. So in that case, if we cut these threads already with the help of the another instrument, which is known as the tap, so very little amount of force is required for overcoming the shearing force. So maximum force is utilized for the compression force, which increases the purchase power. So that is the utility of the tapping. Now, a locking head screw. See, the locking head screw is very shallow thread, where so there is no tap is required. So this thread is very shallow, so no tap is required. So larger core diameter is very larger, so it is very strong. This is a conical countersink. I already told the undersurface of the head is known as the countersink. It may be spherical or the conical. This is the conical countersink, and there is a flute at the tip. So see, these are these two type. See, the one is the flute, but it is a rounded shape. There is also a flute here, but it is a positive rake angle. So this type of screw, it is a self-drilling and self-tapping screw, whereas this type of screw, still, if there is some, the slot is there, but the end is rounded. So this is not a self-drilling, but it is a self-tapping screw. So importance of the countersink. So if it is a rounded one, so if the screw is inserted in an oblique fashion, even without through the plate, that screw inclination, ultimately that will lead to sequential loosening of the screws from proximal to distal. Ultimately that will lead to implant failure. Whereas this conical screw, conical countersink, so if that conical countersink is inserted in a conical space, conical hole of the plate, so that causes very stable fixation that increases the stability. Now this self-tapping, you can see here self-tapping. So and self-drilling, self-tapping especially. So this sort of screws that usually use unicortic damage. So in this case, so there is always recommended this type of stability. Basically, depending on the stability, there are two types. One is absolute stability and the relative stability. And the relative stability or elastic stability or the micro motion that leads to callus formation. Whereas if there is a no micro motion, basically there will no callus formation. Basically, the bone surfaces healed with each other with the help of the remodeling. So basically, it is a primary healing. So the plate will provide the primary healing. There are several years. I am not going into detail. Sometimes examiners may ask when the LCDCP started, when the DCP started, like that. So there are different types of plates depending on the shape, depending on the width, depending on the shape of the screw holes, surface contact characteristics, like that the DCP, LCD will come later on. Internet site of application according to the functions like neutralization, plate vectors, RAM-COM. So LCDCP, basically it is a modification of the DCP. It represents the design change. It will work on the problems with the DCP, and its plate footprint is reduced and minimized kinking at the screw holes. You can see the footprints. So if sometimes what is the basic disadvantage of the DCP? Basically how the DCP acts. DCP acts by the full contact of the plate with the bone. So basically it is a friction between the plate and the bone. This is the main problem. So if it requires some flexion and harmful contact, that will lead to very damage of the periosteal blood supply. So ultimately that will lead to plate-induced osteopenia on the bones underneath. And so that is why, so even after the removal of the plate, there is a possibility of refraction. And that is counteracted by the LCDCP, where there is some part of the metals are taken out so that the bones are deposited on this area. So that will lead to increased strength. Another important point is in the DCP, suppose this is the DCP, if we try to make it bent, to make it proper contour so that the bone is, so it become intimate contact with the bone because it acts by the friction between the bone. So in that case, if we try to bend it, see, these holes are the maximum weakest part. So this basically, it bends unevenly. But if it is the much more metals are taken out from the lower portion or lower portion of the LCDCP, so this process even stiffness throughout the plate. So if we try to bend it to make it intimate contact with the bone, so that will make a smooth bend, not an irregular bend. So that is an advantage of the LCDCP. Now, neutralization plate means we have to fix the fracture with the help of the interfragmentary screw I described, and to protect the interfragmentary screw, if we place the plate just outside that screw, that is basically neutralizes the different types of forces like the axial compression, shearing forces, as also bending and rotational forces. So basically that protects the the interfragmentary screw, that neutralizes by neutralization of the different forces. That is why it is known as the neutralization plate. Another input is a dynamic compression plate, because in the dynamic compression plate, basically the holes have two cylinders. One is the inclined cylinder, and then this is horizontal cylinder. So if we start to place the screw from this end of this plate, so ultimately after the full insertion, the plate is it is glided off. On the other hand, the bone is glided on the other opposite side. That will lead to the compression of the bones. If we make a central placement on one side and the eccentric placement on the other side, that will lead to ultimately the compression of the fracture side. Basically this is the dynamic compression principle, but basically this is a misnomer, because so during the operation we are providing the compression, but there is no dynamic compression. That is, dynamic compression means it should produce compression during the motion, during the joint motion, even after the operation, but it doesn't provide. So that in that sense, dynamic compression plate is a misnomer. So what is the ideal term should be kept in a DCP? Basically it is a self compression plate, because it provides compression operatively, not the post-operatively. Now what are the other compressions methods? There are some external tensioning device like this Muller's compression device is there. So that can be placed some plates. There are some small hole on the at the end of the plate. That's in that case that can be used for this compression. So one screw is applied outside the plate, and then this end is applied on the end of the plate, and one move it as it is increasing, so that will that causes the compression. So that will drag the plate away from the fracture side, and that causes the compression. So basically it is not used always, and there are some other clamps also used as the Verbrugge's clamp. This external tensioning device, either Muller's compression device or the Verbrugge's clamp. These two devices is required for external dragging the plate away from the fracture side by placing the plate on the bones and dragging the plate over this. So this is for the compression. Another is the pre-bending. If there is a 2 millimeter pre-bending is done opposite to the fracture, and near screws are placed just on the side of the fracture, so in that cases there is some compression occurs first on the far cortex, then the compression occurs on the near cortex. Otherwise, without pre-bending, once we give one central screw, that is a neutral screw, another is the eccentric screw. So in that case, what happens? The first compression occurs on the near cortex, whereas the far cortex becomes widened. So there is a gap persists on the far cortex. But if we make a 2 millimeter pre-bending opposite to the fracture, and that causes that uses the strategical screw placement, that is on one side there is neutral screw, another side the eccentric screw, that causes compression first on the far cortex, then the near cortex. Another importance, the DCP, LCT, I already told how the DCP by strategic screw placement causes the compression at the fracture site. Another is the lag screw can be placed to the plate, that can also causes the compression. Now these are the materials which usually used for bending, like the pre-bending, 2 millimeter pre-bending, like the plate bender. These are the different designs of the plate bender. This is a plate bender roller type, and this is the bending press. But basically these are used for bending the plates, basically the DCP plate. Locking plates should not be bent, but there are some other materials. Here, this is basically the LCP, locking compression plate. This is specifically, it can be bent with the help of this. The plate is introduced inside this, so that during the bending there is a very small amount of movement occurring. So in that case, the screw threads will not become damaged. So the other is the reconstruction plate bender. This is the reconstruction plate bender. I will show you. The plate is placed over this, and once we make it widen its handle, that causes the bending. Okay, now the bridge plate principle. See the bridge plate principle. That means the fracture here is avoided. Screws are placed far away from this. But most important, what is the bridge plate? This is usually asked in the examination. Basically, 2 to 3 plate span ratio. So you have to understand what is plate span ratio. Plate span ratio is the total length of the plate divided by the fracture zone. So for the comminuted fracture, the split span ratio should be 2 to 3, and for the transverse fracture, so this should be at least 8 to 10. So 2 to 3 plate span ratio is at least 4 or more cortices. There is, I see, 4 the bone cortices should be kept free is over the fracture zone. And there is, and the screw density. Screw density means number of screws used. That means divided by the total number of screws, total number of holes present in the plate. It should be at least 0.4 to 0.5 plate holes spread screw density, but at least one screw should be inserted as close as possible to the fracture zone within 1 centimeter. Otherwise, that will lead to very unstable situation. So basically, this is the bridge plate principle. And this is the buttress plate. What is the buttress plate? Basically, buttressing is the collapsing of the roof. So buttress is just that would prevent that plate should be placed at 90 degrees to the deforming force. So that prevent the collapse of this buttress plate. That prevents the plate from the collapsing through the healing process. So this is basically the buttressing. Now, what are the plates we have to identify? This is plates we given. We have to identify. This is the 1/3 plate, 1/3 curved plate, and there are some semi-tubular plate. So 1/3 plate should be used for the 3.5 millimeter screw, whereas a semi-tubular plate should be used for 4.5 millimeter. But surprisingly, this thickness is very less. It is 1 millimeter thickness, and the most important, these holes should have collar underneath the plate. Because unless without the collar, if we place the screws and we tighten it, that will lead to deformation of the plate, or that can lead to microfracture once it is tightened. So it has some collar underneath this plate, this hole. So this is the specialty of this 1/3 plate or the semitubular plate. Now this is the Recon. You can see this is the Recon, and see this is this locking Recon. You can see this locking Recon, and this is the LCP with the combi hole. See, this is the combi hole. This is the same one hole at one end is a non-threaded, and that is a threaded. So this is a combi hole. Now tubular plate. So I already told what's the utility, where it is used. There's 1/3 tubular plate or the semitubular plate. It is used for the lateral malleolus, distal ulna olecranon, or the distal humerus. Reconstruction plate. Well, what is the specialty of the reconstruction plate? Basically, the plate can be, the plate has three planes. One is the longitudinal plane, and the transverse plane, and that is the rotational. So most of the plates that can be bent in a longitudinal plane or in its axis, that is by rotational. But no plate can be bent in this manner. So it is along the width of the plate. So only the reconstruction plate is the plate which can be bent in this manner. That is along the width of the plate that can be bent. This is the only plate. So that is the specialty of the reconstruction plate. And that can be used for the pelvis fracture fixation, acetabular fracture fixation, distal humerus, clavicle, and the olecranon. Now this is the Recon plate. But what is the specialty? Because it is a pelvic Recon. What is the difference between the pelvic Recon and the original Recon? So basic difference is a wider shaft. See, this is the shaft. This portion is known as the shaft. The shaft portion is relatively wider in between the holes. This is one. Another important is the thickness. It is much more thicker than the original Recon plate. Now, so specialty is already told because it can be bent in this width. No other plate can be bent along this width. So another, it can be locking, but most important for the pelvic fracture, preferably the locking should not be used, because the bones are very fragile. Sometimes it is osteopenic. In those cases, tactile feeling of purchasing the distal cortex is most important. So if you use the locking Recon for the pelvic fracture, this tactile feeling is usually missed. So in that case, locking should not be used. Locking Recon should not be used for pelvic fracture. This is a catch, is usually asked in the examination. Now, what are this plate? This plate is basically for the periprosthetic fracture fixation. This is used along with the plate, over the plate. So these are the very 2.5, 2.7 system screw can be used on this, and through this, through the original screw is replaced to the over plate. So these are the basically, it is a LCP. This is all are basically LCP. These are the basically, this is the combi hole. You can see here, one side is threaded, one side is non-threaded. There are some curvature. With this curvature, there basically it is for the femur. So what are the types? Basically, there may be DCP, LCP, LCTCP, and LCP. Depending on the width, they are small, narrow, or the narrow 13.5, So narrow, basically it is 13.5. If it is a small, is 11.5. Whereas the broad is a 17.5. So basically, depending on the size, we order this. This is narrow DCB. So what do you mean by narrow? It is asking. So that means its width should be 13.5. Okay. Now this is the less invasive stabilizing system. What is that? So I already told the basically the non-locking plate. Basically, it acts by the friction between between the bone and the surface. Plate is intimately comes in contact with the bone. So, but that causes the periosteal hampering of the periosteal blood supply as the screws are not locked in the hole. So these two problems can be completely obviated with the help of this less invasive stabilizing system. So where the plates are, the screws are completely locked. This is a completely locked system, and that screws are used. Screws are introduced to the help of the external jig. So screws are completely locked inside the thread, and the plates are it is placed little bit away from the bones, so that the periosteal blood supply is not hampered, and there is absolute fixation stability of the screw. That is known as the angular stability. As the angular stability is there, so if the weight is borne from over this, so every screw should distribute that load should be distributed in every screw, so that the no screw should individually bear the weight. This is not the axial stability. Basically, the locking system, because of this, there is axial stability and the angular stability. That screw doesn't have any angular motion at the once it is inserted into the once it is locked inside the hole. So angular stability, as also all the angle, because of the angular stability of all the screw, so it provides the absolutely axial stability. But the problem of the LISS system are the several, because it has a several technical expertise. But at the same time, if you require insertion of the interfragmentary screw through the plate, it cannot be done. Again, the plate cannot produce the compression between the fracture fragment. So that is the this main disadvantage of this LISS, and that to overcome this LISS problem, the LCP has come. LCP has come like this. Okay, so basically, see, LCP is used for the osteoporotic, periarticular, periprosthetic fracture, as also the multifragmentary fracture. As basically, it's change during from the changing from the external fixation to plating. This LCP should be used. So LCP, there is no there is no hard and fast the rules that should be placed away from the bone. That may be contoured, that may be there is a oval, there is a combi hole, one side is threaded, so that locking screw can be used, another side is non-threaded, so the non-locking screw should be used. Even during through the plate, the interfragmentary compression can be achieved with this. So in that sense, if we place this combi hole LCP, so first screw should be used always is a non-locking screw. Non-locking screw should be used first, so for the interfragmentary compression, as after that the locking screw should be used to make it very permanent. See, so this is the at the same time, once all the screws are used for the locking fashion, so once the load, that is a weight bearing load, is equally distributed in all screws, so that it provides excellent stability. So that is not the axial stability. So 2 points: one is axial stability, first is the angular stability, and the angular stability of the screws provide the axial stability. So that is the most important. So in that sense, see, if we use this, like if we fix like this, the fracture gap is kept. So that gap cannot be reduced by mean, because that holds that the bones the stiffness is very important. So in that case, absolute reduction. Now this is another design of the lateral clavicular, and we can tie some ropes on this like vicryls or anything enough. So if it is converted into this, and this see this holes assembly, strong fixation assembly. So this is the modification. But as this is a very basic, it is very very thicker, so it is very difficult to introduce in a MIPO technique through the subdeltoid approach. That is why this has come. This is a low profile MIPO, low profile plate, low profile proximal humeral internal locking system. So what is the specialty through this plate? Basically, the cannulated locking screw can be inserted, and for this, there are some jigs are there. So these jigs are attached over there. Through the jigs, there are some sleeves are there, and through the sleeves, there are some the guide wires can be used. So what is the utility of this cannulated locking screw? Cannulated locking screw, basically that causes the precise placement of the exact or precise placement of the locking screw, that reduces the obbling factor. and that reduces the temperature development. Once if you introduce it, if it is not properly matched in this screw threads, that causes a much more tissue damage, bone damage inside the humeral head. So that can be avoided. So there can be exact placement, and also you have to measure the screw, exact measurement of the screw inside the humeral head, which is mandatory, because in these cases the screw should not pierce the articular surface. Otherwise, that will lead to significant damage of the articular cartilage. And there is a measuring gauge that can be usually used through this. That I will show you how it is used. So this is the low profile proximal humeral interlocking system plate for the cannulated locking screws. Now, these are the distal humerus locking. See how to identify. This is the questions. So this is the lateral plate. This is the lateral distal humeral locking plate, and this is the medial plate. How will you identify it? See the anatomy. So if you see the lateral profile of the humerus, see this is the lateral one. This is the capitulum. Capitulum is remains little bit anterior, and the lateral condyle, lateral epicondyle, it comes along with the capitulum. So this type of plate, there's some lateral post. So if it can be placed, and the lateral side is completely straight enough, it is almost flat. So that can be, it is a dorsolateral plate. It is a posterior dorsolateral or posterolateral plate. It is placed on the flat posterolateral surface. But this because of as the lateral epicondyle is coming on the anterior side, this post, through this post, another screw can be used, can be introduced. So this can be used for the posterior surface, and this is the medial plate. This is a dorsolateral and medial plate. So that those plates that can be used in 90-90 fashion, 90-90 fashion. So okay, so they see this is the lateral plate placed with post, and see this is the lateral plate, all lateral plate, and this is the this is the medial plate. There's the medial plate. Medial plate usually is placed on the medial column, and with some curvature. Sometimes there's curvature is there which embraces the medial epicondyle. Medial epicondyle is much more projected. See the anatomy, medial epicondyle is much more projected. So if there's a much more projection like this cannot be the lateral plate. That should be the medial plate, because through this plate one screw can be introduced from below upwards. So these are the lateral plate and these are the medial plate. And see, the length should be always dissimilar. There's a similar type of length cannot be used on the both sides. But this type of plate, sometimes this is very low articular fracture. Sometimes the parallel configuration plate can be used on both sides, and to interlocking of the screws with each other, so that the most of the bones are in the subarticular bones are locked with each other. So in that case, these are the plates used. These are the plates used on this. So if there's a much more curvature on the medials, that is a medial plate. It is a less curvature in the lateral plate. So suppose this is the medial plate. If it's a much more curvature, this is the lateral plate. See, this type of plates is usually used in a parallel fashion. Okay. Now the ulna. Now this is the ulna. It is a cobra plate. There are different types of plates used for the ulna, as you can see here. This is the DCP. This is the reconstruction plate. This is the LCDCP. This is the LCP, and this is the proximal ulnar prebend plate, or this is the ulnar cobra plate. Main disadvantage of this is this one, because as it is project is a very heavy duty, and that causes projection under the skin, and that causes the ulceration, and that is ultimately failure of the surgery. And that is why this anatomical ulnar plate is a very very low profile anatomical ulnar plate has come. And basically, how will you identify this? In all the all the plates which are basically fixed the subarticular bones, and there are basically two types of threads. One is a very small threads, which is basically the locking threads on the one end, which is a very much more numerous in a cluster, and another in the shaft region, there is some either combi hole or the locking hole in a larger, for the provision of the larger screw. Basically, by this means we have to identify it. This is another this low profile proximal ulnar locking plate. You can see here there are two screws. That screws can be introduced to the tip of the olecranon, and these are the screws should be the conical screws. See, the holes are conical. So the screws are engaged in the hole, that doesn't cause any micro motion. Now this is the distal radial. This is a volar plate. This is the current one. This is the current one. This is the older one, because there is a notion that there are several other fragments to be fixed with this. So that is why these projections are applied before. But this is the very old one. This is the new one. This is the older. These are also the some older, and this is the all the this is the dorsal plate. So these are all these four, these five. These are five is the volar plate, and this is the one which is commonly used, and this is the dorsal plate. So purpose of the slot, this is used. This is for the bone grafting or some synthetic bone graft can be injected through this. Now, what is the limitation of this? This limitation is if there's some associated radial styloid fragment that cannot be purchased to this. That is why this type of plates, see this is small elongation that can be used additionally on the dorsal aspect by erasing the brachioradialis. So this is for this is used for additionally along with this plate for radial styloid process fracture. Now this is the variable angle technology. So I will show what is variable angle technology. The basically is a narrow. See, this is a narrow and this is the wide distal radial locking plate. This is usually sterilized and template is used basically before using that. Which one is required? So template is used either it is a narrow or wide. The template will tell which sort of plate should be used. Now, what is variable angle? So I already told for the DCP, there is the inclination of the screw is possible in 25-degree in longitudinal axis, and there is 7-degree in transverse axis. Whereas see this type of this screw, there's a rounded hole, but there is some inclination is possible. Inclination of the screw is possible up to 15-degree in both sides. In both sides, 15-degree in all sides. You can see at least four sides. 15-degree inclination is possible on both sides of the neutral perpendicular, depending on the fracture geometry. Still, there is some locking. After full insertion, the locking is there. So there is some freedom of placement of the screw at the help of at the same time there is a locking. So both the advantage we are obtaining. So this is the known as the variable angle technology. Now these are the metaphysial or the extra articular plate. So I already told how to identify. So see, there are two sets of holes. One is narrower holes, another is the larger holes. It may be locking or it may be combi hole. This is there's a combi hole. So these are basically the metaphysial plate. Where the extra articular plate, this is the discrepancy of the holes are much more. So in that case, this is the extra articular distal humeral plate. So these are these are used for the metaphysial, the articular fragment. This is a completely locking, whereas these are the combi holes, which is placed for the diaphysial. So these are the extra articular plate. Now the distal femoral locking plate, you can see this is distal femoral locking plate. Again, the cluster of locking holes and another is the combi holes on the other side. So by which we can, so you have to told why it is a distal femoral locking plate, because cluster of holes, and there's a curvature is also there for the anterolateral curvature of the femur. Now what is the difference between these two? See, these are the configuration of the holes. As you can see, it is rounded, but see there are some indentation. That means it is a variable angle technology, but this is the locking technology, single angle locking technology. And another important point is, as see this is the anterior, this is the anterolateral curvature. The anterior part is straight, and this anterior part is little bit curved. That means why? That means it allows the insertion of the interlocking interfragmentary screw, which may be required to hold the interarticular fragment. So sometimes it is required. So as the anterior surface is flat, that can allow that. Now this is the DHS. You can see this is the DHS. Now why the TAD is 20 to 25 mm is required? Because the head, you can see the common diameter of the head is 40 to 48 in our Indian subcontinent. So basically what happens, so once we see the shill out of the head, so we have to keep our implants within inner 75%. Outer, if we keep our if we keep our guide wire in the outer 25%, that is certainly there is a cutout because it is a rounded one. So if you see the shill out, we have to keep our with our guide wire within inner 75% circle of the femoral head. So that means we have to remove the 25%, so one-fourth circumference of the femoral head should be removed. So if it is a 40 to 48 millimeter head, one-fourth means in the AP view, the one-fourth is the 10 millimeter. In 48 means in AP view it is a 12 millimeter. Okay, so yeah, there has to be removed from the center. Similarly, what is TAD? Basically, it is a distance between the center of the head and the proximal most extent of the screw. Center of the head and the proximal most extent, and it is summing of the AP view and the lateral view. So if it is AP view 10 millimeter, it is a 10, and the lateral view is 10, that comes into 20. Similarly, it is a 12 plus 12, it comes into 24. So TAD should be 20 to 24. that is basically to obviate this silhouette effect, as the femoral head is a rounded one. So that is the basis of the head. Now, why 135-degree? Commonly it is, there are several. There is 145-degree, 135-degree, and 125-degree. This barrel angle, this barrel plate angle. There are different 3 types. But why 135-degree is commonly used? Because basically it is because if he increase much more, there's 155-degree, which is basically the sliding angle, that is the placement of that is very difficult. And if he use the 130-degree, that increases the bending up. So if we keep it in middle. So why the screw and barrel length? Because this is the it is used 22 millimeter thread length. There's basically the barrel length. There are 2 types of barrel length: 38 millimeter long barrel, there are some 25 millimeter. If it's a long barrel, then 38 plus 22. That means that is allowable compression is 25. So 85 millimeter will come. So in any screw, it is less than 80. We should use the short barrel. Otherwise, if it's a long barrel, should be. And this is the there is the trochanteric stabilization plate. Use of 3.5 millimeter screw, Ethibond or SSY should be used. This is which sort of screw should be used on this. Okay. And what is the utility of this locking? Basically, you have there's ideally it should tighten it and remove it ideally. Otherwise, it doesn't have after tightening it doesn't have any function. Remove it. So further modification will come there. Why it is called triple rimmer? Basically, it is a quadruple rimmer because it rims for 4 regions. This is for the part of the screw. This is for the shaft. This is for the barrel, and this is for the barrel plate junction. Basically, it's a quadruple, or it is basically it's known as a triple rimmer. Basically, it cuts 4 regions. 4 regions. So how many guide wire inserted? Basically 2 guide wire at least 4 millimeter apart to act as a derotation. And the pilot length is basically the length of the guide wire, which is, and the subchondral bones is 5 millimeter from the articular surface to the lateral cortex. So this is the. Now what is the modification is the made of sliding plate. This is a that causes the biaxial dynamic femur fracture. This is the conventional. It may be in an inverted triangle fashion. Multiple. It is a DHS with CHS, the DHS with anti-rotation CHS, and this is basically the ideal one. This is the now coming in. This is the slight compression anatomical place femoral neck plate, SCAP FN, or basically it is commercial name is the Tardon plate. It is a combination of the control collapse. Control collapse is allowed inside the barrel so that the screw will not be projected inside the outside the plate, and that will provide the rotational stability as also the axial stability. And this is the wise fish. This is under observation. This is not in common practice still now. So that locks this cantilever screw in this manner, and that will provide the rotational as also the axial stability. And this is the proximal femoral locking plate. Why it is a proximal femoral locking? Again, there's a cluster of the small holes, and there are some the other holes. Basically, here it is no combi hole, and there's basically it's a conical hole, which will usually provide the very less micromotion once the screw engages inside the hull. So basically, there are 6 proximal holes instead of 9, which is present in the PHILOS. So 6 proximal hole, and there's the alpha hole and the beta hole. This is the alpha hole. This screw should be introduced first to the scalcar because this is the only constant screw, and that should be used perfectly after reduction of the intracapsular neck femur fracture. And after that, there are these 4 set of beta holes, and then through this 4 set of beta holes, there are different configured. There are different directions holes are placed. So in that case, because after that, all the 4 screw you cannot introduce. Either 1 or 2 is sufficient enough to hold the proximal fragment. And after that, there's a top hole. Top hole can be used from above down. You can use another one for anti-rotation after the sharp screws are used. And see, because of this beveled end, that can be used as a MIPO technique. And basically, it is up here because there are several questions. I think that will be there. I can love to answer this. After that, I can go for the next one. Okay.
So thank you, Professor Pal. That was excellent. I know there's so much to cover. It's difficult to keep it down within the time, but yeah. I think there's a lot of information there which I'm sure will be useful for postgraduate students. So I think there should be questions. Just 1 or 2 things about some I think you mentioned the LCP, or your slide showed LCP being introduced in 2011. Actually, it is a bit earlier. The papers on it were written up in Injury in 2003. By then, it had already been used and tried, and it was actually available in India by 2004.
Okay.
So in 2011, maybe.
Perfectly contoured. So, and once the screw is tightened, plate is intimately contacting the bone, out of the bone.
So Gautam has, and Amit.
Lateral malleolus is going posteriorly. So it is going because of the external rotation of the ankle, the distal fragment of the lateral malleolus is going posteriorly. So if we place the plate on the posterior side and we fix the plate on the proximal fragment, but no screws is used on the distal fragment, just placing the plate, that can prevent the distal fragment to go on the posterior side. That is basically the anti-glide plate. But buttress plate is basically, it is to prevent the collapse of the roof. Suppose in the proximal tibia or the distal tibia, like that, as there is a flaring of the shaft to the subarticular bones. So once there's a weight is borne, there's a chance of collapse of the articular surface. There's a collapse of the bones of the epiphyseal metaphyseal junction. So in that case, if we, again, the principle is same. If we place the plate from the detrimental side where the force is going on, so in that case, plate will prevent the collapse of the, or distribution or the displacement of the fragments. But in that case, we have to neutralize. We have to place the plate in strategically, and we have to place the screws also in the distal fragment. So that is the main basic difference between what
I think basically the anti-glide plate is also a buttress plate, but buttress plate is not. So basically, if you have an oblique fracture which can only displace in one direction, the idea is that if you put a plate in that to buttress that in that particular direction, it will help you reduce the fracture and also hold it there. So you don't strictly need to put screws into that fragment. In reality, we rarely do that. We would, even if we use it initially as an anti-glide, we tend to today put a couple of screws into that fragment as well. But the basic concept is this particular fracture can only displace in one direction because of the obliquity of that fracture. And it's usually only for the lateral malleolus on the posterior aspect, because it tends to go obliquely from anterior to posterior, superior to distal to proximal. And so when you put the plate there, you are actually reducing the fracture as well as buttressing it, and not allowing it to then displace again. While in most situations in buttress, you're supporting the metaphyseal part of the fracture, but you also need to put in screws to hold it because it can collapse in the opposite direction as well. Okay, so you can get a,
exactly.
I think essentially, yeah.
Exactly, yes. The buttress plate, basically that can neutralize the multiple forces, they neutralize. But in the anti-glide place, if the detrimental force is in single direction, that without placing the, basically the functions are same. Yeah.
So another question from Gautam. You want to know the difference between compression if a lag screw placed via plate or without plate.
Yeah. So basically, lagging means what? Lagging means what? It is we have to drag the fragment towards drag the distal fragment towards the near fragment. So that can be done without plate or through the plate. So if it's a large, that is a wedge fragment, that is a butterfly fragment. So in that case, so if we fix the fragments with the help of the screws outside the plate, and we can place the plate in a little bit away from that screw. So that is the lagging effect. That is that screw is placed outside and away from the neutralization. That is a lagging screw. But sometimes that fragment requires some lagging for lagging effect, that screw should be placed through the same direction where the plate is used. Okay, so in that case, plate used first, and the screw, the fragments are held with the help of a K-wire. The plate used first, and through the plate, that one oblique screw is used at right angle to the fracture side. Through the plate hole, the screw is used obliquely. So if the screw has a combi hole or DCP, it can be used. I already told through the combi hole of the DCP, that in 25-degree angles can be done. The screw can be inserted at 25-degree angle in longitudinal axis and 7-degree angle in a transverse axis. So through the plate hole, so first we have to fix the wedge fragment with the help of the K-wire, and after that we will place the plate which has a combi hole or the DCP, and through the combi hole or the DCP, the screw is placed at oblique fashion, so that can be placed at right angle to the fracture side, and that has a similar effect of the lagging. So this is the lagging effect through the plate.
Yeah, so I think here you have to look at it. I think it's absolutely correct what you said, except that any fracture, you can lag in a particular direction, okay?
Exactly.
Ideal direction. So it's an oblique fracture. Now that may or may not be where your plate is going to be.
Exactly.
So if it is going to be in a direction or a surface that your plate is unlikely to be, then you put a separate lag screw.
Exactly.
If you can place your plate and do your lag screw through that, then sometimes it's actually better. If it's a single lag screw, if it's a separate wedge fragment, then usually you would have to put a lag screw separately for that wedge fragment. But if it is like an oblique fracture and you want to put a lag screw through that, if it comes in the direction of where your plate is going to be, then ideally you would put it through the plate. But then you have to plan it accordingly that the hole comes in the area that you want to put the lag screw.
Exactly.
Okay, so lag screw has to be in a direction ideally close to or perpendicular to the fracture surface.
Exactly.
You can vary it a little bit. Now that may or may not be where your plate is going to be, because your plate also tends to be on a particular surface in the bone. So like if you're putting a plate on the tibia, it will be ideal either medial or lateral, but your lag screw may be anterior to posterior. Okay, so you can't then put the lag screw through the plate. Yeah,
Exactly. Absolutely.
Another question asked by him, sir. Order of screw placement in LISS system.
Pardon? Again, please repeat.
Order of screw placement in LISS system.
Order of placement in a LISS system. LISS system, basically, it is not very popular now, because I already told there are several disadvantages. So first, LISS system is basically, it is used for the periarticular fracture. So what is the principle of the placement of the screw in the periarticular fracture? Always we have to start from the articular surface to the away from it. So first we have to start to fix the screws of the articular fragment, then this shaft one. So after that, so again we come to that. So 1 or 2 screws should be fixed in the articular fragment. For anatomical reduction is required, anatomical and the stable fixation. Now come to the shaft again. Then after that we again come to the complete all the articular screws, and again the diaphyseal screws, like that. Okay, and there's maybe a breech fission. So the intermediate screws should be completely kept open.
Sir, another question from him is effect of endosteal blood supply after plating.
Effect of endosteal blood after plate?
Plating, yeah, after putting the plate, sir.
Yes, it is for the non-locking plate. There is significant reduction of the endosteal blood supply. That is why the locking plate has come, which is easily placed outside the periosteum. So there is significant. There are some specific studies are there. There are some dyes are injected through the blood through the blood vessels, and after placement of the plate, again the radiographs are taken, and they have shown that after 24 to 48 hours, there is significant reduction of the blood supply immediately after the non-locking plate. In contrast to the locking plate, there's significant reduction of the endosteal blood supply. There is another question is there. There is what is the basic difference? How much the difference between the two dissimilar plates in the distal humerus?
Yeah.
At least one hole should be bigger. At least one hole should be bigger among this, depending on the area of comminution of the distal humerus fracture. In the comminuted fragment, in comminuted column, the length should be much more bigger, and in the non-comminuted column should be little bit one hole should be less. One hole should be at least 1 inch. It will be more than one.
So when we are using it at 90 fashion, sir, or when we are using it in parallel fashion, that
parallel both parallel or both condition, we have the dissimilar plate, because that will cause, otherwise that will cause significant stress production at the bone plate junction.
Okay, so just to get one thing clear, the LISS system does not have compression screws. Okay, The LISS system only has locking screws. So we don't have the LISS system here in India. We've never had it. It was the original development when the locking system was started with the Pacifics for the forearm, and then you had the LISS for the distal femur. Okay, and these plates had only locking screws. Okay, so even the metaphysis and the diaphysis only had locking screws, and that's when you use the self-drilling screws for the diaphysis, where they were drilled in without measurement, so they were usually unicortical. I think these plates are almost not used anywhere today. What we have today are the metaphysial locking compression plates, or today the variable angle plates. Okay, so the difference being that these plates, for the metaphysis, they only have locking screws like the LISS plate, but for the diaphysis, they have combi holes. Okay, and then you have various companies which have different sort of modifications of it, which have different combi holes and different holes, or alternate locking and compression holes, etc. So don't confuse LISS system and compression plates, because the LISS system, when you say LISS system, LISS system, when you're talking about metaphysial LCP, then what you said is right. Always put compression screws before you put locking screws on one side of the fracture. The only thing about so this thing about locking screws in pelvic plates that you mentioned, so that reminded me. So now you do have some pelvic plates with locking screws. Yeah. Now the problem with locking screws in pelvic and acetabulum is not the fact that the locking is a bad thing. The fact that you normally want to put your screws in different directions.
Exactly.
And the locking screws don't allow it. So today people are using, especially in osteoporotic bone, some locking screws to give you additional purchase and pull out strength. But by and large, you want to be able to put your screws in very different directions.
Exactly.
And if you have only locking holes, then it becomes difficult. So generally the Recon plates don't have locking screws in them, but now you're having some plates developed which have locking screws in them.
Exactly. Locking Recon.
Okay. So in that case, sir, you can use the depth gauge and feel the another cortex. That is okay, sir?
Yeah,
Because
that is okay, but
different ways, yeah.
Sometimes it is not very possible. It's not possible to
you have to be sure you want that screw in that particular direction. Exactly. That is the only thing. So now the pubic symphysis plate has the option of locking screws, the one that's designed by AO. Some of the other ones also have it, but by and large, most people use without locking screws even now. Because of the directions you need to put the screws in.
And one confusion regarding combi hole and variable angle plates, sir.
Yeah.
So how much screw that thing, sir, means how much angle of that screw hole should be?
So most of them, I mean, there are different types, but most of them give you a play of 15 degrees in every direction. So a total of 30 degrees, but 15 degrees, say, suppose you'll put 15 degrees proximally, 15 degrees distally.
Exactly.
And a radius of that. Okay, so
30
different
degree,
directions, 15 degrees that you can do it.
Basically, the non-locking screw that will allow 25 degree longitudinal, 7 degree vertical, 7 degree transverse axis. But that causes the micro motion once the screw engages the hell. But here it allows the 15 degree, 15 degree, 30 degree freedom. At the same time, it allows locking. So that is the freedom of placement as also angle stability. Both we allow.
Sir, I want to know, sir. So out of 360 degree, how much thread should be there, sir? How much degree of thread to get it locking type? That I want.
Can't get you.
So I think 30 degrees of the circumference, okay, to be able to get adequate stability for your locking, okay. So that was 270. Now in the the variable angle, it's a little different, okay, because variable angle doesn't have the classical system, because anyway it has areas within it where you don't have threads, and that is how you can vary the angle a little bit, okay. So it's a little different, and it's hard to quantify it, but for the original, it worked out 270 degrees was the arc that you needed to get good locking.
Two-third of the total work. Yeah.
More than 2/3. It was 75. No, how much did I say?
270 degrees.
That's 3/4 actually.
So I think other Avinash and Sachin, if you have any question, please ask. And Sumit is also here. Avinash?
Yes, sir. Sir, I want to know about the naturalization plate versus tension band plating. The concept of naturalization plate versus
Neutralization plate. Neutralization. Do you mean
what is naturalization plate?
Neutralization plate. Do you mean in neutralization?
Neutralization and tension band.
Yeah. Neutralization plate, I already repeat actually. Once there is some fragment is there and we want to fix the fragment with the help of the lag screw, and lag screw should be fixed at always at 90 degree to the fracture configuration. So
Yes,
first we have to fix this. First fix the lag screw, and then to protect the lag screw, we have to place the plate outside the lag screw. That is to neutralize the different detrimental forces. Basically, the axial forces, rotational forces, and the bending forces. All the forces can be neutralized with the placement of the plate, which is outside away from the lag screw. That is this neutralization plate. Okay, and that's tension band plate is basically if the bone curve is curved. Suppose that the femur, it is curved bone. So one side is tensile, another is the compression side. So if we place the plate on the tensile surface, during the axial compression, that tensile force is converted into compression force. So that is why it is known as a tension band plate. So any plate which is placed on its tensile surface or convex surface, during the axial compression, it converts the tensile force into compression force. That is known as the tension band plate.
So one more thing is that today the term you should use for what we used to call neutralization plate is protection plate. Okay, so AO has stopped using the term. I mean, you can still use it, but the correct term today is protection plate. When you use a lag screw, you're getting absolute stability by way of compression, but that's still not stable for rotation. Okay, so you need to put the plate and shear. So you need to put a plate to protect that. So it's called a protection plate. Okay, now tension band principle is totally different. Okay, the basic principle of tension band works when you have a curved bone. Yes. Okay, and you put the plate on the convex surface of that curved bone with no gap on the opposite side. Okay, that's the only situation where a tension band principle for plating works. Okay, and so when you get eccentric loading because of the bend, normally you would get distraction on the tension band side and compression on the opposite side. Now the tension band then works to prevent this distraction on the convex side of the bone, okay, by converting this distraction force into a compression force. Okay.
Yeah.
So I think you have to be clear about these concepts.
Exactly.
Okay.
Sir, lag screw is compulsory to call the plating system a neutralization.
Yeah.
So again, you're using neutralization. It's a protection plate. Okay.
Yeah, protection, yes.
And so a protection plate protects a lag screw.
Okay. Yes.
Actually, in some books, in older books, it is written in neutralization. That is why.
No, that's what I'm saying. This is a recent change of the
recent change. Yeah.
I mean, neutralization plate is still. If you look at the AO books earlier, it is to call it neutralization plate.
Exactly.
But now recently they've decided to call it a protection plate because it doesn't neutralize anything. So it's just trying to be semantically correct rather than anything else. Okay, so
one question was there.
So absolute stability. The other thing you must understand is absolute stability needs compression. Okay, it doesn't matter how many screws you put in. If you may make it rigid, but you will not get absolute stability unless you have compression across the fracture site.
Exactly.
And the two ways you can get compression across the fracture site is lag screw or longitudinal compression, either using the dynamic compression hole or using the compression device, or some alternative for the compression device like the Verbrugge plate or clamp or something like that.
Yeah, exactly.
One question was there, memory plate. Is there any term like SAPE memory plate? Sir?
It is not. I think in orthopedics, I don't. It is not used. Preferably, previous. It was in a. I think in a very experimental stage. It is especially the non-invasive technique. Basically, it is depending on the shape of the bone. It is specially. So far, I know actually this is an experimental. I don't think it is a practical one. So because of the different types of the shape for the minimalistic technique, it is very difficult to pass the plate and to make the actual matching of the surface of the plate. So in that case, so if there's a fracture, there is some 3D printing is required to make the exact shape of the bone, and following which the plates are prepared, and through this memory plate, shape memory plate can be introduced to the minimalistic technique for the fixation of this particular bone. But I don't think it is commonly used, or still it is used popularly.
So what's this? What was? Sorry, I missed that question.
Shape memory plate.
Sir, it was.
Okay, so I think so. This is just a term again used like shape plates which will try to return to their original shape. Okay, understand?
Yes, sir.
So if you bend it and put it, the trend will be to try to come back to its original shape. Okay. So people use it for compression and things like that, where they would use a plate which is originally made in a particular shape, but when you apply it, you may bend it, and then the forces in the plate will try to get back to its original shape. Okay. So that's what you call a memory plate. Yeah. I think they're using it more with nitinol, which is a new sort of metal that they're using for some of the plates in the foot, etc. And they tend to have a memory. So okay. So you talk
it is made up of different alloy, which is a much more flexible metal.
So where it was being used more was in suture materials with memories. Okay, so when you used silk or something like that, you could put 2 knots and it would be perfectly okay. But when you used nylon, you'd have to put 5 or 6 knots because it had a memory, so it would tend to unloosen if you just put 1 or 2 knots. Yes, because these had a memory that they tended to try to get back to the original shape. Okay, so that's where you talk about memory plates.
I think most of the question we have covered, sir. And if anyone have any doubt still.
Yeah, I think we have already